Bismillah ar-Rahman ar-Rahim. The lecture today, which is the last lecture, about neuromuscular junction disorders and myopathies. Objectives of this lecture is to define myasthenia gravis and its clinical features, to differentiate its diagnostic tools, to list the treatment options, and to approach a patient with myopathy, and listing of main investigative tools, and lastly classify myopathies. Myasthenia gravis is an autoimmune disorder of neuromuscular transmission that presents clinically as fluctuating skeletal muscle weakness, often affecting particular muscle groups preferentially. It is characterized by fluctuating weakness and easy fatigability of voluntary muscles, and there is a predilection for the external ocular muscles and certain other cranial muscles, including the masticatory, facial, pharyngeal, and laryngeal muscles. The respiratory and limb muscles also affected. In myasthenia gravis, the binding of autoantibodies to the postsynaptic receptors disrupts normal neuromuscular transmission. Myasthenia gravis, sometimes associated with thymic tumors, thyrotoxicosis, rheumatoid arthritis, disseminated lupus erythematosus, as an autoimmune disease association. Myasthenia gravis can be divided into two types according to the responsible autoimmune antibodies. First, myasthenia gravis with antibodies to muscle-specific tyrosine kinase receptors, MuSK myasthenia gravis, which constitute 10%. Second, myasthenia with acetylcholine receptors binding antibodies called non-MuSK myasthenia gravis, which constitute 90%. Clinical findings: this disease can occur at any age and usually presents between ages 15 and 50 years, with the women affected more than men in younger age groups, and the reverse at older ages. Although the onset of disease is usually insidious, the disorder is sometimes unmasked by a concurrent illness, which leads to an exacerbation of symptoms. Exacerbations may also occur in pregnancy before menses. Pregnancy may affect the course of myasthenia gravis in an unpredictable way. Worsening of symptoms most frequently occurs in the first trimester or in the first 3 to 4 weeks postpartum. The symptoms may be worsened by medications that may exacerbate myasthenia gravis, which should therefore be avoided in such patients. The patients present with ptosis, diplopia, difficulty in chewing or swallowing, nasal speech, respiratory difficulties, or proximal muscle weakness of the limbs. These symptoms often fluctuate in intensity during the day, and this diurnal variation is superimposed on longer-term spontaneous relapses and remissions that may last for weeks. Clinical examination confirms the weakness and fatigability of affected muscles. The weakness does not conform to distribution of any single nerve, root, or level of the central nervous system, and in more than 90% of cases, the extraocular muscles are involved, leading to often asymmetric ocular palsies and ptosis. The important negative: the pupillary responses are not affected and the sensation is normal, and there are usually no reflex changes. The characteristic feature of the disorder is that the sustained activity of affected muscles leads to temporarily increased weakness. Thus, sustained upgaze for 2 minutes can lead to increased ptosis, with the power in the affected muscles improving after a brief rest. MuSK myasthenia gravis, which may begin as early as childhood with female preponderance. About 50% of patients with MuSK myasthenia gravis present with typical myasthenia gravis finding. The other have predominant weakness and atrophy of the cranial and bulbar muscle, suggesting nerve disease, or prominent neck, shoulder, and respiratory weakness, suggesting muscle disease. These patients frequently have little or no involvement of the ocular muscles, which makes the clinical diagnosis challenging. Suspect MuSK myasthenia gravis if there is an isolated head drop, facial muscle or tongue weakness and atrophy, or weakness that predominates in the neck or shoulder muscles. In non-MuSK myasthenia gravis, the neck flexors are usually weaker than neck extensors, but the opposite pattern is frequently seen in patients with MuSK myasthenia gravis. Diagnosis: The major tools used to confirm the clinical diagnosis of disorder of neuromuscular junction transmission neuromuscular transmission may be divided into three main groups: immunologic, electrophysiologic, pharmacologic. Measuring serum antibodies level often helpful. Acetylcholine receptor binding antibodies are found in 80 to 90% of patients with generalized myasthenia and 55% with ocular myasthenia. Antibodies to MuSK should be measured if acetylcholine receptor antibodies are not elevated. Normal antibody levels does not exclude the diagnosis. It is appropriate to repeat the test after several months if the initial values are normal. Patients with negative acetylcholine receptor antibody may seroconvert later in the course of the disease. Impaired neuromuscular transmission can be detected electrophysiologically, and the electrophysiological studies are performed to confirm a defect in neuromuscular transmission and also to exclude other disease of the motor unit that may contribute to the clinical presentation. The diagnosis of myasthenia gravis can generally be confirmed by the benefit that follows administration of anticholinesterase drugs. The most commonly used pharmacological test is hydrophonium, or what's called tensilon test. Hydrophonium is given intravenously in a dose of 10 mg, of which 2 mg is given initially and the remaining 8 mg about 30 seconds later if the test dose is well tolerated. In myasthenic patient, there is an obvious improvement in the strength of weak muscles that last for about 5 minutes. Alternatively, 1.5 mg of neostigmine can be given intramuscularly with a response that lasts for about 2 hours. The longer acting neostigmine reduces the incidence of false negative evaluations. Atropine sulfate should be available to counteract the muscarinic and cholinergic side effects of increased salivation, diarrhea, and nausea. Atropine does not affect nicotinic cholinergic function at the neuromuscular junction. Patients with muscle-specific tyrosine kinase, MuSK, myasthenia gravis, may become worse or develop profuse fasciculations after hydrophonium. X-rays and CT scans of the chest may reveal a coexisting thymoma, and thyroid function tests should be obtained at the time of myasthenia gravis diagnosis. Treatment. The principles of treatment are to maximize the activity of acetylcholine at the remaining receptors in the neuromuscular junction, and then to limit or abolish the immunological attacks on motor endoplate. The treatment of myasthenia gravis include: first, symptomatic non-immune treatment by cholinesterase inhibitors. The treatment with these drugs provides symptomatic benefit without influencing the course of the underlying disease, and the mainstay of treatment is the pyridostigmine at doses individually determined. Over-medication can lead to increased weakness, which, unlike myasthenic weakness, is unaffected or enhanced by intravenous hydrophonium. Such a cholinergic crisis may be accompanied by pallor, sweating, nausea, vomiting, salivation, and colicky abdominal pain and meiosis. Patients with MuSK myasthenia may become worse or develop profuse fasciculations even with low doses of pyridostigmine, in which case it should be discontinued. Second, immune-directed therapy of myasthenia gravis may be divided into short-term rapid onset therapies and long-term therapies. A. Long-term immune-directed therapies, which accomplished by corticosteroid, which are indicated for patients who have responded poorly to anticholinesterase drugs. Treatment is initiated with the patient in the hospital, as weakness may initially be exacerbated. Alternate day treatment is helpful in reducing the incidence of the side effects. Azathioprine can be used in patients with severe disease and in progressive disease despite treatment with anticholinesterases and corticosteroids and thymectomy. It can also be given in place of high doses of corticosteroids to patients who show no sustained benefit with low doses. Thymectomy usually leads to symptomatic benefit or remission, but beneficial effect may not be evident immediately, and is the only treatment for myasthenia that carries a realistic probability of drug-free remission. Thymectomy is performed to potentially avoid chronic immune suppressive therapy, or if immune therapy has failed or patients have had intolerable side effects from immune therapy. It should be considered early that's to say within 1 to 2 years after onset in patients between 15 and 50 years old. Other immune suppressive drugs can be used in patients with no or poor response to azathioprine, like mycophenolate mofetil, rituximab, cyclosporine, cyclophosphamide, and methotrexate. Rituximab may be considered as a treatment option in patients who develop unacceptable side effects or have not responded to adequate use of other immune therapies. And the muscle-specific tyrosine kinase MuSK myasthenia gravis patients often require more aggressive immune suppression, particularly early in the course of the disease, and the consideration of rituximab in this patient is the mainstay. Short-term immune-directed therapies like plasmapheresis and intravenous immunoglobulin. Plasmapheresis may be used to achieve temporary improvement in patients deteriorating rapidly or in myasthenic crisis, and in certain special circumstances such as prior to surgery that is likely to produce post-operative respiratory compromise and to overcome dipping in patients with steroid therapy. While intravenous immunoglobulin have also been used to provide temporary benefit in circumstances similar to those in which plasmapheresis is used. Medications that impair neuromuscular transmission should be avoided, like aminoglycosides, gentamicin, streptomycin, macrolides, erythromycin, azithromycin, fluoroquinolones like ciprofloxacin, levofloxacin, calcium channel blockers, beta blockers, statin drugs, phenytoin, penicillamine, and finally lithium. Special therapeutic situations. In patients over 50, the concurrent illness is a major factor in determining the best therapeutic approach. Myasthenic crisis is the classical definition of myasthenic crisis is weakness from myasthenia gravis that is severe enough to necessitate intubation or ventilatory support or airway protection. It is estimated that 20% of patients with myasthenia gravis will suffer myasthenic crisis at some point during their illness, and all patients with severe myasthenia exacerbations producing prominent oropharyngeal and respiratory muscle symptoms should be managed in an intensive care setting with frequent and close monitoring. Indications for intubation generally include evidence of respiratory muscle fatigue with increasing tachypnea and declining tidal volumes, hypoxemia, hypercapnia, and difficulty with secretions. In general, patients with forced vital capacity of below 1 liter will require mechanical ventilatory support. A precipitating factor can be identified in most cases of myasthenic crisis, and the most commonly include one or more of the following: bronchopulmonary infections, aspiration, surgical procedures including thymectomy, corticosteroid-induced worsening, a rapid tapering of immune modulators, and exposure to drugs that may increase myasthenic weakness. Because of rapid onset of action, plasmapheresis or IVIG is the favored treatment for myasthenic crisis, and discontinue the use of anticholinesterase inhibitors and avoid using steroids during the myasthenic crisis. Cholinergic crisis. The excessive dosing of cholinesterase inhibitors can potentially increase weakness due to depolarization blockade. In addition to weakness, manifestation of cholinergic hyperactivity will be present, such as excessive salivation, increased bronchial secretions, muscle fasciculations, and abdominal cramping. Some elements of cholinergic crisis can be treated with antimuscarinic drugs like atropine, but the most important element, like respiratory arrest, cannot. Such a patient will require mechanical ventilation support via endotracheal intubation until the crisis resolves on its own. Respiratory compromise from cholinergic crisis has no pharmacologic solution or therapy. Ocular myasthenia gravis is the designation given to patients who have signs and symptoms solely in the ocular muscles, eyelid elevators, and extraocular muscles. Ptosis and or diplopia are usually the initial symptoms of myasthenia gravis in up to 85% of patients, and almost all patients have both symptoms within 2 years of disease onset. If weakness remains limited to the ocular muscles after 2 years, there is 90% likelihood that the disease will not generalize. Ocular symptoms are adequately controlled with cholinesterase inhibitors. Steroid therapy may delay or reduce the frequency of progression of ocular myasthenia to generalized disease, but thymectomy usually avoided. What about the prognosis? The maximum disease severity is reached within 2 years of disease onset in 2/3 of the patients, and in most patients the active stage of the disease characterized by relapses and remission, which may last 7 to 8 years. This is followed by a relatively inactive stage lasting approximately 10 years and a final stage of burned out disease. It is important to recognize that during the inactive stage of myasthenia gravis, disease exacerbation may still be precipitated by intercurrent illness, exposure to drugs that adversely affect neuromuscular transmission, or pregnancy. Lambert-Eaton myasthenic syndrome. It is a presynaptic neuromuscular junction disorder characterized by a triad of proximal weakness, reduced or absent tender reflexes, autonomic disturbances such as dry mouth, postural hypotension, and erectile dysfunction. The males affected far more than females, 5-1. Difficult in walking is the initial symptoms in most Lambert-Eaton myasthenic syndrome patients. Bulbar and ocular muscles are usually spared or only mildly affected. Strength improves immediately after exercise in 20% of the patients. Lambert-Eaton may be discovered when prolonged paralysis follows the use of neuromuscular blocking agents during surgery, and weakness may be exacerbated by agents that also worsen myasthenia gravis. Diagnosis: the voltage-gated calcium channel antibodies are elevated in most patients with LEMS. Diagnosis of LEMS is confirmed by typical electrodiagnostic findings, and the hydrophonium testing or pyridostigmine improves strength in some patients, but this is rarely as dramatic as in myasthenia gravis. Treatment: the cholinesterase inhibitors does not usually produce significant improvement in Lambert-Eaton syndrome, although they may improve dry mouth. Treatment is directed to the concomitant tumor. The use of amifampridine results in moderate to marked neurological improvement in 80% of patients. As in myasthenia gravis, plasma exchange or IVIG produces relatively rapid, albeit temporary, improvement in most Lambert-Eaton myasthenic syndrome patients. Immune suppressions are usually much less effective. Now, myopathies are a heterogeneous group of disorders of a primary, functional, or structural impairment of skeletal muscle. The approach to a patient with myopathy: there are 3 goals when evaluating a patient with myopathy. The first goal is in approaching a patient with a suspected muscle disease is to determine the correct site of lesion. Second is to determine the nature of myopathy, and third is to determine whether a specific treatment is available, and if not, to optimally manage the patient's symptoms to maximize his or her functional abilities and enhance quality of life. Clinical evaluation: history, the age that symptoms begin, can provide crucial information leading to the correct diagnosis. Clinical features: weakness is by far the most common negative symptoms reported by the patient with the muscle disease. If the weakness involves lower extremities, patient will complain of difficulty climbing stairs. When the upper extremities are involved, patient notices trouble lifting objects over their head and brushing their hair. These symptoms in the arms and legs indicate proximal muscle weakness, which is probably the most common type of weakness in myopathic disorder. Some myopathies may also result in cranial muscle weakness, resulting in complaint of dysarthria, dysphagia, or ptosis. The fatigue is a much less useful negative symptom. Positive symptoms associated with myopathies may include myalgia, cramps, contractures, myotonia, and myoglobinuria. Myotonia is the phenomenon of impaired relaxation of muscle after forceful voluntary contraction, and most commonly involves the hands and eyelids, and myotonia is due to repetitive depolarization of the muscle membrane. Myoglobinuria is a relatively uncommon manifestation of muscle disease and is caused by the excessive release of myoglobin from muscle during periods of rapid muscle destruction, which is called rhabdomyolysis. Temporal profile: the temporal evolution of the disorders with the constant weakness can vary among First, acute or subacute progression in some inflammatory myopathies like dermatomyositis and polymyositis, chronic slow progression over years, most muscular dystrophies, non-progressive weakness with little change over decades, as in congenital myopathies, and 4, episodic. Precipitating factors that trigger episodic weakness or myotonia. Heavy meals may precipitate attack of weakness in patients with periodic paralysis. Cold may precipitate myotonia. Fever and exercise precipitate weakness in types of hereditary metabolic myopathy. Family history of myopathic disorder. Skeletal deformities or functional limitations are usually more informative than questions such as, does any member of your family have a muscle disease? Examination. Inspection first. Muscle should be inspected for evidence of atrophy or hypertrophy. Muscles can show evidence of hypertrophy in some myotonic conditions such as myotonic congenita, and muscle hypertrophy is also characteristic of disorder including amyloidosis and hypothyroid myopathy. In Duchenne and Becker dystrophy, the calf muscles demonstrate pseudohypertrophy due to replacement with connective tissue and fat, and calf muscles hypertrophy is also characteristically seen in limb-girdle muscular dystrophy. Focal muscle enlargement can also be due to neoplastic or an inflammatory process or tendon rupture. The distribution of weakness is to determine the distribution of muscle weakness. Is important to know which muscles to test and how to grade their power. Involvement of cranial nerve muscles such as orbicularis oculi, orbicularis oris, extraocular muscles, tongue and palate should be detected. Associated systemic illness. So, involvement of organs or tissue other than muscle may also provide helpful clues in making the appropriate diagnosis. So, cardiac disease may be associated with myotonic dystrophy, Duchenne or Becker muscular dystrophy. Respiratory failure may result from myotonic dystrophy, muscular dystrophies, and congenital myopathy. Hepatomegaly may be seen in metabolic myopathies, and dysmorphic features may be associated with congenital myopathies, and musculoskeletal contractures can occur in many patients with long-standing duration. Evidence of diffuse systemic disease can indicate amyloidosis, endocrinopathy, collagen vascular disease, or infectious disease. The laboratory approach in the evaluation of suspected myopathy, creatine kinase enzyme CK is the single most useful laboratory study for the evaluation of patients with a suspected myopathy. The CK is elevated in the majority of patients with a muscle disease, but may be normal in slowly progressive myopathies. Serum test for other muscle enzymes such as aldolase, aspartate aminotransferase AST, alanine aminotransferase ALT, lactate dehydrogenase LDH. Electrophysiological studies consisting of both nerve conduction studies and electromyogram should be a part of the routine evaluation of patients with suspected myopathy. Nerve conduction studies are typically normal in patients with myopathy, and needle electromyogram can also provide clues as to which muscles have had recent or ongoing muscle injury, and can be guide as to which muscle to be biopsied. Muscle biopsy. If the clinical feature and or electrodiagnostic feature suggest the possibility of myopathy, muscle biopsy may be an appropriate test to confirm the diagnosis. However, many forms of hereditary muscle disorders can now be diagnosed with molecular genetic testing, thereby eliminating need for muscle biopsy in every patient. Muscle specimen can be obtained through either an open or closed needle or bunch biopsy procedure. Biopsy should generally be taken from muscles that demonstrate great force strength, and the best muscle to be chosen is the vastus lateralis, lower limb, or deltoid or biceps muscle or deltoid in the upper limbs. Molecular genetic studies. The specific molecular genetic defect is now known for a large number of hereditary myopathies, and the mutations can be identified by peripheral blood DNA analysis. Molecular genetic testing frequently eliminates the need for muscle biopsy, and this technology is also extremely helpful for determining carrier state and for performing prenatal testing. Other tests include serum electrolytes, thyroid function test, parathyroid hormone levels, and the human immune deficiency virus (HIV), and urine analysis can also be performed to detect the presence of myoglobinuria. Now, classification of myopathies: hereditary, muscular dystrophies, dystrophinopathies, myotonia, limb-girdle dystrophy, facioscapulohumeral FSH, emery-derived muscular dystrophy, and oculopharyngeal muscular dystrophy. Other type of hereditary is the congenital myopathies, and then metabolic muscle disease like mitochondrial respiratory chain disease, or glycogenosis and lipid storage disorders. And the most important is the skeletal muscle channelopathies, which is called periodic paralysis. Other class of myopathies is the acquired, which include inflammatory myopathies, nutritional myopathies, endocrine myopathies, drug-induced myopathies, toxic myopathies, and lastly alcoholic myopathies. Muscular dystrophies. The muscular dystrophies are a group of inherited myopathic disorders characterized by progressive muscular weakness and wasting. They are subdivided by their mode of inheritance, age at onset, distribution of involved muscles, rate of progression, long-term outlook. Now we talk about dystrophinopathies. The example of it is the Duchenne muscular dystrophy, which is an X-linked disorder that affects predominantly males. Symptoms begin by age 5 years, and patients are typically severely disabled by adolescence, with the death occurring in the third decade. Toe walking, waddling gait, and an inability to run are early symptoms. Weakness is the most pronounced in the proximal lower extremities, but also affects the proximal upper extremities. In attempting to rise to stand from a supine position, patients characteristically must use their arms to climb up their bodies, which is called Gower sign. Pseudohypertrophy of the calves caused by fatty infiltration of muscles is common. The heart is involved late in the course, and mental retardation is a frequent accompaniment, and serum creatine kinase level are exceptionally very high. Regarding treatment, there is no definitive treatment available. Prednisolone may improve muscular strength for up to 3 years. Deflazacort, which is a prednisolone analog, is effective with fewer side effects than prednisolone, and what is new, which is a new gene therapy. It is etiplursin, which is an FDA approved drug, but it is unclear whether treatment confers any clinical benefit, and the death usually is from respiratory insufficiency or cardiac arrhythmias. Other type of dystrophinopathies is the Becker dystrophy. It is also X-linked and associated with a pattern of weakness similar to that observed in Duchenne. Its average onset and age at death later than that of Duchenne dystrophy, and cardiac and cognitive impairment do not occur. Myotonic disorders. In myotonia, an abnormality of the muscle fiber membrane, which is called sarcolemma, leads to marked delay before the affected muscles can relax after a contraction. This leads to apparent muscle stiffness. Myotonic dystrophies is the most common adult muscular dystrophy. It is usually autosomal dominant with genetic anticipation. Weakness typically becomes obvious in the third to the fourth decade, although it may appear in infancy or early childhood. And initially involves the muscles of the face, as you see. This results in distinctive facial appearance, which is called hatchet face. Hatchet means dalu, kaddalu, characterized by ptosis, temporal wasting, drooping of the lower lip, and sagging of the jaw. Myotonia manifests as a peculiar inability to relax muscles rapidly following a strong exertion, for example after tight hand grip and eyelids, as well as by sustained contraction of muscles following percussion, for example thenar eminence, when there is a dimple after pressure on it. Associated problems can include frontal baldness, posterior subcapsular cataracts, gonadal atrophy, respiratory and cardiac problems, endocrine abnormalities, intellectual impairment, hypersomnia or sleep apnea or hypopnea syndrome, complete heart block, which are maybe life-threatening. Myotonia can be treated with the quinine sulfate, procainamide, or phenytoin 100 mg 3 times daily. In myotonic dystrophy, phenytoin is perhaps the drug of choice, since the other drugs may have undesirable effects on cardiac conduction. There is no treatment for the weakness that occurs, and pharmacologic maneuvers do not influence the natural history. Myotonia congenita, which is called Thomsen disease. It is usually inherited as a dominant trait. Generalized myotonia without weakness is usually present from birth, but symptoms may not develop until early childhood. Muscle stiffness is enhanced by cold and inactivity and relieved by exercise. As you see in this picture, there will be muscle hypertrophy, sometimes pronounced. You can call it Herculean habitus of the body. It is also a feature. A recessive form of myotonia congenita, which is called Becker's disease, with later onset, is associated with slight weakness and atrophy of distal muscles. Treatment with the quinine sulfate, brokinamide, mexiletine, or phenytoin may help the myotonia. Now we talk about hereditary metabolic myopathies, and the example is the CHANNELOPATHIES. The periodic paralysis is the example. These disorders occur as either inherited or acquired illnesses and can be further classified according measurable alterations in the serum potassium level during the attacks. Hypo or hyperkalemia may also lead to muscle weakness that is rapidly reversed by correcting the metabolic disturbance. The familial primary type occur at adolescent, which is due to channelopathies, which is an inherited abnormalities of the ion channel in striated muscles. The men are affected more than the women, and the episodes of flaccid weakness or paralysis, which may be associated with abnormal plasma potassium level. The power is normal between the attacks, and the most common type is hypokalemic periodic paralysis. The second type, which is called episodic weakness with onset after age 25, which is called secondary type, is never due to periodic paralysis except for the thyrotoxic type, and is often provoked by heavy carbohydrate meal or sodium rest after prolonged exercise or certain drugs. The features of proximal more than distal weakness are clear, with intact reflexes, and the muscle power is normal between the attacks. The treatment is achieved by acetazolamide Diamox and giving potassium in mannitol for rapid absorption. Regarding inflammatory myopathies, it can be classified as idiopathic, as dermatomyositis, polymyositis, inclusion body myositis, B, infective, post-infective, C, polymyalgia rheumatica, and D, myopathies associated with systemic disease overlap syndrome, like inflammatory myopathy occurring in patients with connective tissue disorder, such as mixed connective tissue disease, and E, other subtypes include necrotizing myopathy, granulomatous myositis, and eosinophilic and eosinophilic myositis. Regarding nutritional myopathies, the proximal muscle weakness may also occur in osteomalacia, often with associated bone pain and tenderness, mild hypocalcemia, and elevated serum alkaline phosphatase. Strength improves following treatment with vitamin D. Endocrine myopathies. Myopathy may occur in association with the hyper or hypothyroidism, hyper or hypoparathyroidism, hyper or hypoadrenalism, hypopituitarism, and acromegaly. Treatment is that of underlying endocrine disorder. Lastly, drug-induced myopathies can occur in association with administration of certain drugs like corticosteroids, chloroquine, clofebrate, aminocaproic acid, certain beta blockers, colchicine, zidovudine, or drugs that cause potassium depletion. Thank you very much.